I thought, so as a dermatologist and a dermatopathologist, I'm typically involved very early in the process of the diagnosis and management of melanoma. And so I thought I would concentrate mostly on that aspect and also talk a little bit about things that you can do moving forward. So most of what I do is actually at this level, we look at melanomas under the microscope. But I thought I'd start with just an exposition of the microscopic structure of the skin, which is actually quite remarkable. You can see that within just a cubic centimeter of skin, there are an amazing number of structures, including yards of blood vessels and nerves, over 100 sweat glands, 300 sensory neurocutaneous cells that actually sense the environment, sebaceous glands, hairs, and over 300,000 epidermal cells. Most of what we'll talk about today are about things that occur here in the very superficial layer of the skin, which is the epidermis. So we'll concentrate mostly here on the very upper layers of the skin, namely the epidermis. And if you look up close, this is what it looks like under the microscope. Here are the epidermal cells. This is the epidermis here. These are the layers of keratin that overlie the skin, forms its waterproof barrier. And underneath here is the dermis, which invests the skin with structure, elasticity. This is what gives strength to the skin. All of the cells within the skin are capable of giving rise to cancer. If we just restrict ourselves to the epidermis, we're talking about basal cell carcinoma arising from these very bottom cells of the epidermis, more differentiated keratinocytes, which give rise to squamous cell carcinoma, and the pigment-producing cells, the melanocytes, of which there are about 1 every 10 or so of these basal cells along the bottom of the epidermis that give rise to melanoma. What that picture fails to capture is that melanocytes actually are very complicated cells. They, when you look at it more of a 3D view of these cells, you'll see that these cells have multiple projections. They're thought to contact up to 30 to 40 keratinocytes, transfer melanin to them, and that's what actually gives skin its pigmentation. In the course of development, melanocytes arise from a structure called the neural crest. They migrate through development to invest the entire epidermis, your entire skin, with melanocytes. And melanocytes can actually be found in the heart, the inner ear, the back of the eye, as you'll see later, where they have actually non-pigment related functions. And it's thought that biologically this intrinsic capability to migrate is what makes melanomas so dangerous. You're all familiar with benign melanocytic proliferations. These are moles or nevi in technical parlance. These typically start out as flat, dark brown spots. Under the microscope, this is what they look like. These are little balls of melanocytes that have lined up at the bottom of the epidermis. In time, these moles may expand. They may actually reach into the dermis here, as you see here and here, and they may actually get to something that looks more like this. And these are benign melanocytic proliferations or moles. About 20% of melanomas are thought to arise from pre-existing lesions such as these. And so the question is, well, how do we actually get to a point of diagnosing melanomas and telling the difference between benign proliferations and malignant ones? So as pathologists, this is typically what we do. We get a specimen of skin from the dermatologist, from the surgical oncologist, and we do something called breadloafing. Literally, it's like slicing it into slicing bread. We then take these slices of bread, we flip them down, we embed them in wax, and then we cut very thin layers of this tissue. We stain them with two things, one which labels proteins, one which labels DNA. And from that, we can tell a lot of things about the architecture of the cells and what they look like. But the two main questions we're seeking to answer in doing this, what is it? Is it melanoma or not? Is it benign or malignant? And number two, what is it going to do? Because ultimately, what this information provides, and I hope I'll convince you of this, is that there's actually a lot of information that's contained in that one biopsy, that one initial specimen. Now, The dilemma comes about because, as I mentioned before, about 20% of melanomas can arise from pre-existing moles. The problem is this process of a benign nevus evolving into a potential melanoma is a continuous process. However, the diagnosis of melanoma is not a continuous process, right? You either make the decision that this is a melanoma or it's not, or that it's going to be treated like a melanoma or it's not. So that actually is where a lot of the dilemmas around the diagnosis of melanoma at this stage take place. And I will tell you that nothing gives dermatopathologists and dermatologists more headaches than melanoma. This is the one area of dermatopathology and dermatology that rightfully so gets the most attention in terms of diagnosis because of its difficulty, and I hope to highlight that in a little bit. One of the very important things that we look at under the microscope are what we call architectural features. So this is the Houston skyline, and you can see already that there are a number of things you can tell, right? Is this a symmetric distribution of buildings? Are the buildings closely packed together? What do the individual buildings look like, and how are they formed? This is not unlike what we do under the microscope. This is a benign mole. It's largely symmetric, as you can see. It basically, if you were to flip it on this axis, it would look the same. If you zoom down a little bit and you look at the individual cells, they're small. They're pigmented up here. They lose their pigment at this layer essentially evenly. The nests or the groups of cells get smaller until you see basically single cells all the way here at the bottom. This is what we call maturation, but this is benign cytology. So we look at the individual cells, their shape, how they're distributed. And so between these two features, we arrive at a diagnosis of whether the lesion is melanoma or not, whether it's benign or malignant. This is a moderately abnormal nevus, okay? You can see that the borders are a little bit shaggy here. There's some variation in the color. And you can see architecturally, if you look even at this very low power under the microscope, the distribution of cells is uneven. You've got some inflammation here. You've got some big aggregates of cells. You've got some smaller aggregates of cells here. If you zoom in a little bit, now you see that there's some changes going on here in the dermis. The cells are no longer evenly distributed. And in time, this can evolve into, this is melanoma in situ, where the cells are now lining up continuously along the basement membrane, along the bottom of the epidermis. Remember that I told you before, normal melanocytes, there should be only about 1 for every 10 cells along the bottom of the epidermis here. Now you can see that they're basically lining all the way along, and these are the big cells here that you see. This is an invasive melanoma. You can see that these cells are very large. They're very unusual, or atypical, as we say. And the pigment is distributed all over the place, not in a very organized pattern. So this is a full-fledged invasive melanoma. Now, there are a lot of features about melanomas once they're diagnosed that are very informative for what we call prognostic, in terms of prognostic information. And the size of melanomas is actually one of them. So we measure that by something called depth. We simply take the largest piece of melanoma we can find under the microscope. We measure from the top of the mid portion of the epidermis all the way down to the deepest portion of the melanoma, and we get something called depth. So you'll see here a melanoma that's 1 millimeter thick has a very good outcome at 15 years. You can see that as the melanomas get thicker, this decreases dramatically. And it's estimated that a 4 millimeter spherical mass of cancer probably contains on the order of 20 to 40 million cancer cells. There are 2 specific additional features at this point that are often very important for staging. One is ulceration, whether or not the top of the epidermis has been breached by the melanoma. And the other is something called mitotic rate. If you look here and you look here, these are cells that are undergoing the active process of dividing. These are cancer cells that are actively dividing. We count them under the microscope, and that number can give us information about how aggressively the melanoma is expected to behave. Ultimately, staging, something that we call staging, is the key to predicting the behavior of these melanomas. You can see that something that's called stage 1 has excellent outcomes. Stage 4 is obviously a much worse outcome. But the key thing to remember here is that these are overall averages. In fact, a lot of research is ongoing now to determine why there's so much variation in, for example, stage 3 disease or even stage 1 disease for people who may relapse many years later. Many of the characteristics I just talked about were about the tumor itself. How big is it? How fast is it dividing? Has it breached the epidermis? That's often the starting point here. We do, of course, as you'll hear later on, there's a detailed evaluation of whether there is lymph node involvement or distant metastases. These 3 factors all figure into the staging, ultimately, and the predictive algorithm that gives us an idea of how the melanoma will behave and ultimately what can be done about it. Okay, so what can you do? I sort of divided this part into 4 areas. One is, of course, know your risks, and I'll go over a little bit about that. One is protect yourself sensibly from the sun. Practice skin self-examination, and that's something you can do, of course, on your own with a mirror, as well as in conjunction with follow-up with your dermatologist and or your spouse or significant other. With respect to risk, there are things that you can't change, whether or not you're fair, red, blonde hair, light eyes, whether you freckle easily. These are individuals who are typically what we call types 1 or 2 skin. They burn immediately in the sun, or they burn and then they tan right after. All of these things confer on average about a 2 to 5-fold increased risk of cancer, of melanoma, including an increased number of benign moles, abnormal moles, very large congenital nevi in children, particularly those that are over 20 centimeters in size. Most important thing I want to highlight here, probably perhaps most relevant to many of you, is that the history of a prior melanoma in and of itself confers a 5 to 10-fold higher risk over the general population for a second melanoma. The vast majority of cases will arise in the first 2 years after the initial diagnosis. So follow-up, particularly early on, by a dermatologist, by your surgeon, is very important within this time period. With respect to the things that you can change, we'll talk some bit about sun protection and surveillance. So how do we, so I wanted to highlight, as you all know, that sun exposure is dangerous because of the UV, ultraviolet light that's contained in sunlight. Now, the reason that's so is that UV light actually directly damages DNA. And in doing so, it basically modifies the DNA. The enzymes that then copy the DNA make a mistake based on this abnormal product that's formed as a result of this chemical reaction with UV light. Mammals, unfortunately, lack the endogenous capacity to repair this type of defect. In fact, this enzymes to repair this, called photolyases, are present in some animals, bacteria, fungi, and plants, but not in mammals. As a result, if you take a 1 centimeter, square centimeter piece of skin from the upper eyelid that has been chronically sun damaged, but actually has no evidence of any tumor or abnormality, every circle here represents an abnormal clone of keratinocytes. So this was taken from a 55-year-old woman who had eyelid surgery for cosmetic reasons. This is the mutational load found in that 1 square centimeter of skin, which really highlights how dangerous UV is in the sense that how powerful it is as a mutagen and as a carcinogen. Recent data from deep molecular analysis of melanomas shows that the number of mutations in melanoma can exceed several thousand. And actually, it was thought for a long time that melanomas actually had the most mutations of any human cancer. In fact, we now know that keratinocyte-derived cancers that are from the layers a little bit above melanocytes actually have 4 to 5 times even greater number of mutations. So the exposure to UV light is a very, very important component of inducing skin cancers. And you can see here in the orange bars here, the majority of mutations induced in melanoma actually have a characteristic signature this signature here that highlights that chemical reaction as a result of exposure to UV light has occurred. Okay, so what do we do about it? Okay, so my toddler here is illustrating 4 examples of sun protection. First, she's wearing a wide brim hat. She's wearing sun protective clothing. She's avoiding the midday sun by walking outside at 8 a.m. And she's applied, with a little bit of help, sunscreen, SPF 30, that contains zinc and titanium. And I mentioned zinc and titanium specifically because these are physical blockers of UV. They are not absorbed in the skin. The only downside to them is that they actually have an opaque sheen, so they do alter your skin tone a little bit. And reapplication and application prior to exposure is critically important. So just to recap, avoid the midday sun, use sunscreen and hats, sunglasses as needed, sun protective clothing. Remember that tanning is an injury stress response. If it has occurred, you have damaged your skin. It is a protective response, but it's only there because you have damaged your skin by exposure to UV. There's a lot of controversy now about whether or not aggressive sun protection can result in vitamin D deficiency. Vitamin D supplementation costs about a cent and a half a day, so take a pill. In terms of what to look for on your skin, this is a very difficult thing. We don't expect you to be diagnosticians. The only lesion on this panel that is not a melanoma is this. This is a melanoma. This is not a melanoma. So I urge you to look for a few things. One is certainly asymmetry, shaggy borders, differences in color, and diameter over 6 millimeters. Those are things that I think have been out in the literature for a long time. But one of the most important things that you can keep track of, that clinicians and your caretakers can't always keep track of very well, is evolution. So things that change over time. That's something that should always be brought to the attention of a dermatologist or a clinician. So with that, I'll wrap up. I just wanted to credit some of the images that were supplied by George Murphy and Susan Chan. Unfortunately, I have to leave very soon after this presentation, but you are all welcome to contact me via email should you wish to do so. Thank you very much.